Good morning, everyone. Today we are examining the various factors that influence individuals' decisions about reproductive health services. These decisions are rarely based purely on medical information. Instead, they are shaped by emotions, social norms, culture, ethics, economic realities, and the level of trust in healthcare providers. Understanding these decision drivers is essential for providing care that is respectful, effective, and patient-centered. In this session, we'll examine each category of drivers, how they operate, and their practical implications for health professionals. RH decisions are rarely purely clinical. Instead, they arise from a blend of health concerns such as fertility issues or managing pregnancy, values and emotions like fear, hope, anxiety, or moral beliefs, social influences, including partners, family, and community opinions, economic considerations, such as affordability or opportunity cost. Understanding these drivers helps improve service uptake. People are more likely to access services they trust and understand. For instance, a woman might avoid visiting a contraceptive clinic if she fears judgment, even though the service is medically safe. Recognizing these barriers, like fear, stigma, or peer influence, helps us design programs that encourage timely and appropriate service use. Counseling quality. Counseling isn't only about conveying medical facts. Effective counseling addresses emotional, social, and cultural factors. For example, a provider explaining the side effects of an IUD while addressing common myths can reduce anxiety and improve adherence. Adherence and continuation. Patients continue a method or treatment when it aligns with their values. For example, a couple may consistently use condoms if counseling respects their religious or cultural beliefs, rather than feeling imposed upon. Continuity of care. Understanding barriers such as transport challenges, stigma, or family influence ensures patients attend follow-ups, maintain preventative care, and avoid complications. Continuous engagement leads to better health outcomes. Now that we understand why decision drivers matter, let's examine the main categories that shape these choices. Several broad categories shape RH decisions. Emotional drivers. Decisions influenced by fear, hope, anxiety, or desire. Cultural and religious norms, traditions, taboos, and expectations shape what behaviors are socially acceptable. Ethical and moral considerations, dilemmas related to abortion, IVF, or adolescent consent. Socioeconomic realities, access to finances, transport, or household support affects feasibility. Risk perception and trust. Beliefs about medical risks and the reliability of providers influence choices. Provider and health system factors, quality, availability, cleanliness, staff behavior, and infrastructure affect uptake. These categories help explain why two patients with the same clinical need may make different choices. For example, one woman may readily adopt contraception due to trust in her midwife, while another may refuse due to misinformation in her community. Let's begin with emotional drivers, the first and perhaps most personal category. Emotions strongly influence RH choices. These may include fear of pain, side effects, and infertility. Many patients avoid services due to fear of discomfort or potential harm. For example, women may reject IUDs, fearing cramping or infertility, although these concerns are often exaggerated. Desire for reassurance, compassion, and privacy. Patients seek empathy and confidential consultations. A young woman may avoid clinics if she perceives staff as judgmental or if privacy is compromised. Anxiety from community stigma and misinformation. Peer pressure, rumors, or social disapproval can prevent service use. For instance, adolescents may avoid STI testing, fearing adverse reactions from peers or family. Emotional desire linked to infertility or recurrent pregnancy loss. Individuals experiencing infertility often make decisions driven by hope or desperation, sometimes favoring advanced technologies like IVF despite high costs or risks. Hope and optimism are closely tied to advanced technologies. Patients may invest financially and emotionally in treatments like IVF because they believe in a positive outcome, even when success rates are not guaranteed. After emotions, cultural influences are another powerful force shaping choices. Culture shapes how individuals understand reproductive health through patriarchal decision-making. Men or elders often influence reproductive choices. In some families, women must get spousal approval before using contraception. Cultural expectations for large families. Societies that value prominent families may discourage family planning, as they often prioritize the number of children in a family. Preference for male children. Couples may continue childbearing until a male child is born, impacting contraceptive use. Norms restricting adolescent access to SRH. Cultural taboos may prevent teens from accessing contraception or STI services. Traditional beliefs about menstruation, pregnancy, and infertility. Some communities view medical interventions as unnatural, discouraging service utilization. Next, we examine how religion intersects with cultural norms to affect decisions. Religious beliefs can guide or restrict reproductive health behaviors. Religious teachings on contraception. Some faiths oppose modern methods, allowing only natural methods, which affects uptake. Influence of religious leaders. Community leaders may advise couples against specific treatments, shaping health behaviors. Faith-based gatekeeping. Some faith-based facilities restrict abortion, sterilization, or contraception, directly limiting access. Now that we understand cultural and religious influences, let's look at ethical considerations that arise in RH choices. Ethical issues often influence client decisions. Moral status of embryos in IVF. Patients may struggle with what to do with leftover embryos, creating ethical dilemmas. Ethical dilemmas around abortion, emergency contraception, religious, familial, or personal beliefs may conflict with medical advice. Consent and autonomy issues for adolescents. Teens may want contraceptives but face legal or parental barriers. Pressure from families versus personal moral beliefs. Individuals may feel tension between following family expectations and their own values.
Having explored these foundational elements, we now turn to patient expectations in RH services. Patients expect different things based on the type of RH care. Family care. Expect personalized, holistic care. Patients value human connection beyond medical procedures. High expectations of success. For infertility patients, hope for guaranteed outcomes is common. Desire for confidentiality. Sensitive topics require privacy to avoid social stigma. Maternal care. Expect respectful maternity care, including dignity and emotional support during labor. Preference for familiar providers like known midwives or birth attendants. Preference for culturally sensitive birth practices that respect safe traditions. Patients also expect technical competence and transparent communication. Let's now look specifically at patient expectations in contraceptive care. In contraceptive decision-making, patients often expect competent, caring care. Skilled providers with empathy boost patient confidence. Honest, non-judgmental communication. Clear explanations about procedures, risks, and side effects are essential. Detailed explanation of side effects. Knowledge reduces fear, increases adherence, and fosters informed choice. Desire for choice and autonomy. Patients wish to participate in decision-making, sometimes involving partners. Let's shift to how much effort different RH decisions require. Some RH decisions require more effort and thought. Examples: IVF, IUI, egg freezing, tubal ligation, vasectomy, and abortion services. Characteristics: long deliberation over weeks or months. Multiple consultations with family, peers, and providers. Ethical and familial considerations heavily influence decisions. Low-involvement decisions, on the other hand, are often faster and more practical. Examples: switching contraceptive methods due to side effects, routine antenatal checkups, STI testing. Characteristics: quick decisions requiring minimal contemplation, influenced by service availability and convenience. Understanding high versus low involvement decisions helps tailor counseling strategies. Change to quick decision, method switching is often low involvement. Stable to low involvement decision, routine checkups require minimal thought. Choosing a contraceptive method is high involvement because long-term effects, social context, and side effects require careful deliberation. Risk perception is another crucial factor in reproductive health decision-making. Risk perception often differs from actual medical risk. Fear of side effects and infertility may outweigh long-term benefits of effective contraceptives. Social risk, fear of judgment or partner violence, can override medical reasoning. Misperceptions about medical risks, such as myths about IUDs or IVF, deter uptake. Over- or underestimation of pregnancy, STI, or antenatal risks influences behavior. This leads us to a major determinant of decisions: trust. Trust emerges from patient trust varies. Midwives may be trusted for empathy, doctors for technical expertise. Confidentiality is critical, especially for adolescents and infertility clients. Clear, responsive communication builds trust. Respect, dignity, and consistent treatment outcomes encourage ongoing service use. Lack of trust can lead to reliance on self-care or pharmacies instead of formal services. Trust is strengthened by the credibility of the provider. Credibility comes from reputation in the community influences choice. Perceived competence and experience matter for complex procedures. Perceived expertise in specific services, such as fertility treatments, increases uptake. Clean facilities and modern equipment reassure patients. Alignment with cultural and religious beliefs builds confidence. Affordable, transparent fees foster trust. The key system-level influences include availability of drugs, supplies, and contraceptives impact uptake. Long waiting times and stockouts deter patients. Staff attitude affects the decision to access services. Adequate privacy and infrastructure increase utilization, especially among adolescents. Outreach and engagement by community health workers enhance knowledge and trust. Let's now look at how these drivers differ across key populations, starting with women. For women, decisions often reflect the desire to meet partner or household expectations affect choices. Child spacing or desire impact method selection. Fear of social consequences may influence uptake. Concern about side effects affects decisions. Limited financial resources constrain access to expensive services like IVF. Let's now focus on adolescents, a group with distinct needs. Adolescents often face adolescence. Peer pressure strongly influences behavior. Confidentiality concerns can reduce access. Fear of judgment deters service use. Legal restrictions limit independent access. Men. Masculinity norms influence family planning decisions. Financial considerations affect participation. Limited SRH literacy may delay seeking services. To make sense of all these factors together, we now explore an integrated model. This model includes individual factors, knowledge, attitudes, beliefs, interpersonal factors, partners, family, peers, community norms, traditions, expectations, health system quality, accessibility, competence, reliability, structural or policy environment, laws, regulations, societal infrastructure. For example, a young woman may want contraception, individual, but face parental disapproval, interpersonal, cultural taboos, community, and stockouts at the clinic, all shaping her final decision. This integrated view helps inform practical strategies. Understanding decision drivers enables practitioners to strengthen respectful, non-judgmental counseling, engage partners and families when appropriate without compromising autonomy, build trust through transparency and consistent care, expand community education to address misconceptions, integrate adolescent-friendly and male-inclusive services. Now, we conclude with a summary of the key insights. RH decisions are influenced by reproductive health decisions are multidimensional and context-dependent. Emotional, cultural, religious, ethical, and systemic factors matter alongside clinical considerations. Fear and perceived provider credibility strongly affect uptake. High-involvement decisions like IVF, permanent contraception, and abortion need enhanced counseling and support. Understanding decision drivers enables better, human-centered care, improving outcomes and satisfaction.